All right. So this is work from the recovery registry entitled Clinical Prediction Rule for SARS-CoV-2 Infection from 116 emergency departments. And I'm presenting, but I'm also presenting on behalf of over 45 individuals.
This is my first time working today.
And you can see here our steering committee and the members of those, and I thank them for this. So the objective of this work was to create a prediction rule to estimate the probability of SARS-CoV-2 infection and to create a simple set of criteria to rule it out without the use of any or imaging. And we putatively called this the cork rule along the lines of the PERC rule. And could I ask everyone to mute their microphone, please? These data were abstracted from individuals who presented to emergency departments from across the United States, representing 27 different states, and in this case, 116 hospitals. All of the patients were symptomatic and they were swabbed for SARS-CoV-2 with RT-PCR detection. And everyone had a questionnaire or a red cap form filled out. And this was done partially by automatic download, but mostly by hand query by trained research coordinators who all used the same manual of operations. And our initial sample size was over 20,000 patients, expecting that 1/3 would be positive. So the manuscript of this work is published, and the methodology for the registry is also published in JSEP Open, and here's the title of it. Over here on the right are all of the individuals who participated in this network, the Recover Network. Importantly, when I present this to you, I want you to recognize that this timeline shows that we abstracted data from what we call the indexed visit. That's the visit usually when the patient was swabbed for SARS-CoV-2. But at the time, we were trying to determine what symptoms were associated with SARS-CoV-2, because when we started this over a year ago, we still weren't quite sure what the clinical picture looked like. So the data are extracted from the first ED visit that happened within 14 days of the day that the patient was swabbed. And then we followed everyone for 30 days. So we have 30-day outcome. Anyone who converted from negative to positive was considered positive. So you had to have either serial negative testing or no negative testing to be considered negative for SARS-CoV-2. So we did the typical thing. We used 50% of the sample for derivation, 50% for validation, had to do some imputation for missing body mass index. And we also went ahead and used stepwise methods, which were univariate, multivariate, because in prior work, we found that this was as good as using any machine learning techniques, such as gradient boosting or random tree methods. So again, the typical univariate followed by stepwise forward logistic regression done in SPSS to find the overall PERC rule or cork rule. And we started with almost 20,000 patients, split it in half. Prevalence was what we expected to be 30%. And started with 107 variables that we selected based on really our expertise as to what we thought would be predictive. And by univariate analysis, 72 went into the logistic regression equation. So it's a lot of equations, but there were over 4,000 individuals in the derivation set that were target disease positive. So there was really not overfit with the model because we had so many outcomes. And ultimately, this is what we've developed is the cork rule, which you can see there's +1 values and -1 values, which were taken from the coefficients off of the logistic regression equation. Importantly, the data drove the decision to include race and ethnicity as part of the predictive criteria. This is somewhat controversial because individuals will say, well, there's no reason why race or ethnicity should increase or decrease the probability of infection. So it's really, these are surrogates probably for social reasons that these individuals either had + or -1 score. And otherwise you can see there's age, symptoms, exposure, and then 2 vital signs. And smoking, interestingly, is a -1, and that has been consistent across multiple databases that people were less likely to have infection if they smoked. Left-hand curve shows the overall receiving operating characteristic curve, which actually had an AUC of 0.8, not 0.75. And then this is the precision recall curve. And that's really not as important, I think, as looking at this, and that is the overall diagnostic performance when we set the cork rule at 0, and that's using the score, adding up all the points. If the patient has 0 or a few points, the sensitivity is 96%, specificity 20%, producing an LR ratio, a likelihood ratio negative of 0.22. And this is in the validation set of 9975 patients. So that's the performance in the split sample, not the derivation sample, in the actual validation sample. And it also produced this nice stepwise increase in probability on the y-axis for the number of points in the cork score, as you would expect a stepwise method to produce. So when you had fewer than 1 point, 0 or less, you were a very low probability. When you had 5 or more, you were very high probability. And those are the two ends of the extreme to be able to use the rule. We then went on and tested the inter-rater reliability of the cork rule and score. And I just want to point to the column that says weighted kappa. And we did this in 1,000 patients prospectively. And the kappas were very good for the overall cork score. And this is absolute agreement for the numeric value, a kappa of 0.613. And for the either 0 or higher binary cutoff of the cork rule, the kappa was even better at 0.644. So it does look like it has reasonable inter-rater reliability. And we also went on and tested the cork rule prospectively in real time. And you can see the numbers of patients here in the 2x2 scores. And the most important thing I want to point out is in the bottom row of the diagnostic performance of the cork score on the left is that the LR negative held up, and it was very similar to what it was in the validation or the initial derivation and validation populations from the registry at 0.24. So it seemed to validate. And this was using it real time, actually using it in the emergency department in March of 2021. And we also asked physicians to give their gestalt, their best estimate as to what they thought the probability of SARS-CoV-2 was on these same patients, and their likelihood ratio negative is much higher at 0.57, significantly higher. So it looks like the cork rule in these individuals, these persons, which were, of course, all levels of training as well as faculty, was better than their gestalt. In comparative literature, here are 4 studies that have tested rules that did not include laboratory or radiographic data. And one thing I want to point out is none of these have been prospectively tested. In fact, actually, none of them were really tested in a true validation population, even like a split sample. There's no inter-rater reliability, and none have been compared with gestalt. So I think the cork rule has the best validation as of now. So in conclusion, the cork rule score of 0 or less produces a likelihood ratio of approximately 0.24 for the detection of a SARS-CoV-2 infection. And to our knowledge, this is the only proposed clinical prediction rule that does not include laboratory studies, does not include radiographic studies, that's been prospectively tested. And it could be going forward that this prediction rule could help exclude SARS-CoV-2 at the bedside in unvaccinated patients. And with that, I'll thank you. Happy to take any questions. Okay, is the moderator in the room?
The moderator is not here. Okay. Does anyone have any questions for Dr. Klein?
Hi, Jason.
If you don't want to ask them out loud, feel free to put them in the chat.
Hi. So I'm James. I'm here at SAEM21. I gave the speech to Nick already, but so.
Sorry, I couldn't hear the question. Or I couldn't hear what was.
I didn't hear any question.
So
okay. Hearing no questions, I think it's time that we move on to Dr. Gordon.
All right, let me get presentation ready for you. Great. Is that okay? I'm going to assume that looking good. So I'm going to start by thanking you for being present on this virtual adventure we're all on to hear my presentation about a documentation quality improvement project we performed in Minnesota at Regents Hospital. In particular, I'm going to focus on a resident population subgroup analysis we did. The project didn't, and my co-authors had no disclosures to give you, and we feel that timely and succinct documentation are critical components necessary for quality patient care and provider satisfaction. We believe that notes are timely notes certainly are needed for each other when the patient comes back for another visit, but also to hospital care providers if the patient's admitted. And certainly we know that most providers didn't get into medicine for the documentation perks. And so we wanted to create a project for all of our department to improve how we were documenting. And we feel that in particular, we found that residents reported that they felt more satisfied and ready for their career if they got better training and documentation. But as we evaluated our training, we found that we did very little training of residents. We had a much more of a sink or swim model, and they would maybe learn from each other, good practices and bad. And that particularly came in the case as more scribes, former scribes came into work as providers. They would often bring some of their scribe habits in as providers, which aren't always great for efficiency. So we then set forth to evaluate the timeliness of notes on patients' charts created by resident physicians before and after this documentation improvement project. Okay. The intervention was about 1 BC, and that's my joke of the day here, is that was 1 year before COVID in April 2019. And we were at a single large urban emergency department. We've later spread this to our non-teaching hospitals, so it's worked pretty well. And we have an established EM residency. And like many of you, we use Epic, and we have since 2005. And we also use voice recognition. We had, as part of this project, we actually transitioned from Dragon to Fluency Direct. So we have experience in both of them, but voice recognition is a key part of our documentation system. You know, to get in specifically to the intervention first, we train now to start a note early in the visit, ideally right after you leave the room and enter orders, which is what most people are doing. And this gets the note on the chart early and often before or in parallel with the workup. Then Epic has a tool that's called the ED course, and we recommend to our providers to use this tool to document further along during the visit. I almost try to call it live blogging the visit to some extent. And at the end of the visit, then you'll go back and re-sign the note or create an addendum of your first note. And because of the tools in the EHR, the data you put into this ED course and the clinical impressions automatically load up into that draft addendum. So this is a pretty unique thing for Epic, I think. And you sign that addendum and the note is complete. And so I felt fairly compelled to just show you graphically what this looks like with a screenshot that I didn't have to get approval for, so I mocked one up. And basically on the left side of the screen, you can see a patient list, and this is one of the places you can get to this little box where you can add text into a chart. It's time-stamped, and then a chronologically sequenced set of those smaller notes appear at the bottom of the visit note. And so basically we're prompting people to sign this note before it really has much of an ED course in it, or it has just an initial medical decision-making. The evaluation methods we used here were basically a retrospective post hoc subgroup analysis, and we decided to include all of the residents except for the class that graduated basically right after this change. Most of their data would be in the old system, and so we just decided to focus on providers who had substantial data in the new system. And so our rationale there was that we really wanted to see people who had pre and post data, but we also were very interested in how quickly could a new group of people, particularly the interns, pick up this new documentation system. And so we definitely wanted to look and include their metrics. The metric specifically we want to explain is this note to departure interval, which is basically just the distance in minutes between when the note was signed and when the patient departed the emergency department. That could be an admission or could be a discharge. In this first timeline mock-up, this patient showed up at 9:36 in the morning. The note was signed at 11:15, and the patient departed at 12:10. And so that gave what we computed to be a negative 55-minute note to departure interval. And then in a second example, I've lined these up basically with departure time, and the patient in this case arrived around 12:20 a.m. I'm sorry, at 12:20 in the afternoon, departed at 2:45, and then the note was signed after departure at 3:55. So that gave a positive 50 note to departure interval. So as I'm trying to indicate with color here, the lower NDI is better, including negative numbers, and the negative indicates that the interval was, or the note was signed before departure. So into more of the aggregation methods, we computed the NDI on all visits where the first provider note was signed by one of these included resident physicians as our main inclusion metric, inclusion criteria. And the note time is the time that the first signing occurred. I'll talk much more about that in a moment. And we aggregated the NDIs for each encounter into basically monthly medians to look at the monthly medians over time. And we decided to find the average of those medians and compute their confidence intervals. And we decided to also monitor the dichotomous sort of success rates of signing before disposition, as that was how we communicated to providers. Our goal was to try to get notes on charts before the patients left, as a very clear and succinct way of describing the goal. And so success in this case was the NDI being less than 0. Our results are on the top demonstrated just simply the quantity of encounters included, and I broke it down by class because of our decisions to include the interns but exclude the outgoing residents. You can see that they're somewhat unequal, about 3,000, 4,000 more visits in the post-intervention group, and each class was growing in capacity, the number of patients they were seeing in that same quantity of time at 6 months. Our primary outcome is in the lower half of the lower table, and that demonstrates that the pre-intervention group had an average median of -5 minutes, and the post-intervention group had a basically 2 hours earlier, about 126 minutes before the patient's departure. And the success percentages, as I mentioned before, went from 61% to 92%. I have the same data here graphically, where the shaded areas indicate the confidence intervals, and we just simply show that these monthly medians drop substantially to 2 hours before the visit. And we're pretty stable across time. They weren't substantially changing better or worse. The important step that I want to kind of introduce here is that we decided to use this first sign analysis because it represented when a large chunk of the providers' thinking and findings and what HPI were available for other people to use, which we felt was an important part of care delivery that we were missing out on.
Hi, did this freeze for, oh, there we go.
Okay, and so we presented that data, but hopefully still presenting well. So our final sign analysis, I'm just going to keep going, is that if we looked at when the last time the note was signed, which we didn't present in the abstract, we didn't really see a substantial difference before and after this intervention. It's important for us to, I'll talk a bit about more of that as I talk about limitations, but the quasi-experimental approach that we use at a single site is likely not generalizable, as I mentioned in this quality improvement project, but the approach might quite be implementable anywhere. The early sign of this note and our analysis of it may appear as a yardstick change to some, because we're changing the workflow and changing how we're maybe measuring when those notes are signed. But we think that this was pretty important to get the note on the chart earlier for a few reasons I'll mention. Also, we're not able in this presentation to show you balancing metrics, or we didn't perform them at the resident level, such as patients per hour or the charge level mix or satisfaction data in detail. So in more of conclusion and discussion, we think that with a combination of the right tools and training, provider documentation can appear nearly real time. And this particularly was true for resident physicians. And we think that even if we were to use a more conservative, looking at this final signing time, our new method is not inferior to the old one, but the notes are available earlier in the visit, and they're much easier to teach and supervise residents when the notes are available real time than they were before, which is an important aspect of trying to help improve our educational process. And the residents are satisfied with this change. The resident physicians adapted amazingly and led much of the charge in this project. And so we're very thankful. We probably couldn't have done this without their open-minded thinking to the future. So in conclusion, it's definitely possible to get real-time, near real-time notes done in a visit with a modern EHR and tools. And I meant to mention earlier on that we don't have a scribe program anymore, and we never use them for residents in this analysis. So with that, I'll conclude and ask for your questions.
There were no questions entered into the chat, Dr. Gordon. Next up, we have Dr. Bray.
Thank you.
Thank you very much.
Yeah. Okay. Hi, everyone. Thank you for coming today. So I'm going to talk about leadership communication, stress and burnout among frontline ED staff during the COVID-19 pandemic. So, oops. Oh, and then just quickly that neither me or my co-authors have any relevant disclosures. So some background, the COVID-19 pandemic has taken a significant toll on the mental health of frontline healthcare workers. We can see examples of this in the popular press, like this New York Times article, and also in research, which has found increased symptoms of depression, insomnia, and anxiety among healthcare workers who have been exposed to COVID-19, in addition to elevated rates of stress and stress-related conditions. And this, of course, was especially prevalent for healthcare workers in emergency departments who were consistently working on the front lines. So organizations and leaders have a key role to play in supporting healthcare workers and mitigating their stress during, times of crisis. And a key way for them to do this is through effective crisis communication and information dissemination, which should help to mitigate healthcare worker stress and anxiety. Research tells us that a lack of access to information can increase anxiety. However, there is little empirical research that's investigated the effects of effective communication on healthcare worker stress during the pandemic. So that led us to our question, which was, do perceptions of communication by local leadership reduce stress and burnout among frontline healthcare workers? And is this relationship mediated by perceptions of support? So to answer this question, we collected data from 3 emergency departments in a large multi-site health system. One ED was in an academic hospital, one in a community hospital, and the last was a freestanding emergency department. The 3 EDs see a combined total of about 190,000 patients a year. And we collected this data during the first peak of COVID-19, so from April 9th to June 15th of 2020. And we employed a mixed methods approach to answer our question and collected 2 types of data. So the first was from a web-based survey, which measured our primary outcomes of work stress and burnout, among some others. And this was a repeated survey. So what happened was healthcare workers were texted a link to the survey 15 minutes after the end of their shift. And then that happened every six shifts over the course of the study period. And there was an opt-out option if they didn't want to continue to receive the links. And all healthcare workers in the ED were eligible to complete the survey and receive the link. So that included attending and resident physicians, along with APPs, clinical and administrative nurses, and patient care technicians. So we received a total of 327 responses, which gave us a response rate of about 76%. And then our second set of data came from a series of in-depth interviews conducted with frontline workers in the ED. They followed a semi-structured interview protocol and were conducted on the phone to keep everything safe. And we collected or completed 64 interviews with ED staff. And then those interviews were analyzed using a grounded theory method. So they were coded and we extracted relevant themes from the interviews to sort of help answer our question. So quickly before we get into the results, I'll just tell you a bit about how our key measures and constructs were captured in the survey. So communication was measured with the following question, which was, how useful are the communications you're receiving about the COVID-19 response from the hospital? And similarly, support was asked the question, how supported do you feel by the hospital right now to do your job effectively? And then we measured stress with a 3-item scale developed by Lippman, and that sort of asked questions about your levels of stress and how you manage it. And then finally, we looked at burnout using the Copenhagen burnout inventory, which asks a series of questions measuring burnout specifically for in the healthcare setting. And then those questions were like later scaled to give a 0 to 100 measure, where 0 is the least amount of burnout and 100 is the most. So the first set of results I'll share are from an OLS regression looking at the effect of leadership communication on stress and burnout. So the first column will show the results for work stress, and our coefficient of interest is the first line. So we see that there was a negative and significant reduction in work stress when providers perceived communication to be more effective. And that was robust to the inclusion of controls, including the number of possible COVID patients in the ED, as well as just the total number of patients, and then controls for occupational role. And these results can be also interpreted as sort of a 1 unit increase in the communication scale was associated with about a 9.5% reduction in stress among the healthcare workers. And so the second column shows the same results, but for burnout. So again, this first coefficient is the one of interest, and it also shows a negative and significant reduction in burnout associated with improved communication, and includes the same controls as the first. So this is a 1 unit increase in communication was associated with about almost a 19% reduction in burnout for healthcare workers. And so the next set of results I'll show you are from a mediation analysis, where from the interviews, we heard a bit, it seemed that communication might have been making the workers feel more supported. So we ran these results to sort of help us disentangle the extent to which communication itself was directly alleviating stress and burnout, or whether it worked to do so by sort of increasing perceptions of support among the staff. So here's a path diagram. So we found the first step. So from there's a positive relationship where communication was increasing feelings of support. And then that support decreased the amount of work stress. So this basically helps us see that healthcare workers who perceived communication to be more effective in turn felt more supported by sort of leadership, and then that reduced their reported levels of stress at work. And so we ran the same thing for burnout and very similar results. Again, positive effect of communication on support and negative for support on burnout. So we see again that it sort of travels through the same way where communication increases support and decreases burnout. And lastly, I will show you a few results from our in-depth interviews, which we sort of investigated to see if perhaps there were specific types of communication that were especially beneficial at like bolstering feelings of support and reducing stress and burnout. So we found 3 types of communication that seemed to be effective at doing this. The first was information consolidation. There is a lot of potential for information overload with all of the changing care models and such that were happening rapidly as the crisis unfolded. So here's a quote from one of the healthcare workers that said, it was a little much at first because things were changing so frequently, but it seems like now we have a system in place. And if anything new is changed, it's highlighted in the update, and this thing seems to be communicated better. So when information was consolidated prior to being disseminated to the healthcare workers, that seemed to have a positive effect. There was also consistency of communication. And so this was illustrated in a quote here describing a daily email that consolidated pertinent information and was sent out at a specific time every day. And so the person was like, it was like the Bible. You would look for it at exactly 6 in the morning. And I know to me as a leader, that was huge. I felt well informed through this whole thing. And then if I feel good about it, I'm able to articulate that to my people. And then the third type of communication was bidirectional. So rather than communication occurring sort of solely from higher ups in a top-down manner, workers were also able to communicate with leadership directly from the bottom up to share their thoughts and concerns with those who were in charge. And so here's an example of that. They have these town halls, which are phenomenal. I have to hand it to them. They're trying to keep the communication open with the staff. They're honest with us. They need to keep that openness and transparency because that's vital, because rumors get started. So basically these town halls happened once a week throughout the crisis, and everyone in the ED could sort of attend, and they discussed things that were changing and issues that they might have, and they could bring these things up to their leadership. So this work establishes a link between communication and resilience, demonstrating that communication was associated with increased perceptions of support and decreased work stress and burnout. It also highlights the importance of effective communication. So our qualitative interview showed that communication alone wasn't enough to sort of reduce stress and burnout, but effective communication characterized by those 3 things, information consolidation, consistency, and bidirectionality, did seem to help. We also highlight the benefits of inclusivity and opportunities for broad participation, especially during times of crisis. And so things like the town halls, which allow people to sort of go up and share their concerns. And taken together, we think that these findings offer a framework for leadership to effectively communicate with their workers in a crisis, hopefully reducing stress and burnout along the way. And that is the end. Thank you. Happy to answer any questions.
We had no questions in the chat, so the next person up is Dr. Webb.
One sec.
I can't hear you.
Can you hear me?
Yep, now I can.
Okay, great. Okay. Hi, everyone. My name's Emma. I'm a student researcher at Beth Israel Deaconess Medical Center, and I'm going to be talking about our project mapping electricity-dependent patients in hurricane flood zones. And I have nothing to disclose. So the problem that we are really interested in is that an increasing number of patients in the US are becoming dependent on electrically powered DME, like oxygen concentrators, nebulizers, home hemodialysis machines, things like that. And this renders them incredibly vulnerable in the event of a power outage, because that puts them at risk for device failure and the associated adverse health outcomes, which can contribute to ED usage in the days following that event. And so this is a really critical issue because we're also seeing an increasing frequency and severity of climate-related extreme weather events like hurricanes, heat waves, snowstorms. And this picture that you're seeing is actually part of a video that was taken during Hurricane Sandy, when a Con Edison substation exploded in Manhattan, leaving millions of people without power. And so these weather events are putting enormous strain on the power grid, which is already susceptible to outages due to outdated infrastructure and high baseline demand. For example, just a few months ago, we saw the Texas power infrastructure fail during a series of winter storms due to inadequate preparation for those kinds of conditions. So there's a really urgent need to develop methods of identifying these patients early who are at high risk of power outage during disaster-related events, who are also dependent on electrically powered DME to address ED surges and the preventable morbidity and mortality in this population. And we think we can begin to address this by identifying where these patients reside and which of those areas are most vulnerable to inclement weather. So our goal for this project was to create a reproducible methodology for identifying and spatially mapping patients who use nebulizers and home hemodialysis. And so what we did is we used a retrospective chart review of a single hospital system looking through de-identified medical records to map a subpopulation of these patients who we believe to be members of these categories based on proxy measures. So either having been prescribed at least one nebulized medication or having a documented creatinine value of 3 or more within the past year. And we extracted data on 3,406 patients in Massachusetts alone, 2,099 of which were nebulizer users and 1,307 of which were hemodialysis patients. And so once we identified this patient population, we used ArcMap to create choropleth maps at the census block and tract level to show where these patients reside. And you can see here that this is the tract level map for privacy reasons, but blocks with fewer numbers of patients are colored lighter and blocks with more patients are colored darker. And I don't know if anyone's familiar with the Boston area, but you can really see some hotspots in Dorchester and Revere where the darkest blue colors are. And so our next step was to isolate only those blocks and tracts that would intersected hurricane flood zones. So we did this by downloading shapefiles from the state of Massachusetts showing which areas would be flooded by different categories of hurricanes, and then trimming our map just to those zones. And we did this by isolating tracts at risk of flooding in the event of a hurricane. And so that's the map you're seeing here. It's the same concept as the first map, with tracts with fewer numbers of patients colored in yellow and higher numbers of patients colored in darker red. But these are the only tracts that are intersecting those flood zones that we identified. And so this was really our first goal, to identify the tracts and blocks at risk of flooding from any category of hurricane. And then our next step was to stratify those blocks by hurricane category to determine which would be at risk in a category 1 storm, category 2, 3, or 4, because obviously the odds of a category 4 storm occurring are much different than a category 1. And these are the results. And so the main take-home finding here is that almost 25% of these patients that we identified who use nebulizers or hemodialysis at this one hospital are at risk of flooding in a category 4 storm. And then even in a category 1 storm, just over 300, or about 9%, are still at risk. And that number almost doubles when you move up to a category 2. And so this was a huge finding for us, because we mapped just a small percent of the total electricity dependent population at a single hospital, but this is already a large number of people that are at risk. So the take-home point for this project is that we were able to develop this relatively simple, non-complex, reproducible methodology that really only requires a basic understanding of GIS that can be used in any hospital system and yields very valuable clinical data. And there are a bunch of applications for this. We think it could be feasible for any healthcare system to determine which of their high-risk patients might benefit from disaster preparedness counseling. So for example, ensuring they have enough batteries or medical supplies, or knowing where the nearest generator access is, which is a more proactive approach than relying on patients to sign themselves up for registries or priority restoration lists. And these results also show a need for focused preparedness efforts to address the needs of this population and prepare for increased ED utilization by patients with respiratory complaints or who are presenting for hemodialysis in the event of a major hurricane. And then on a similar note, this can also be used for more long-term systems level resilience planning. For example, anticipating what facilities might become isolated in the event that access roads are cut off, or anticipating which EDs are going to need extra staffing or extra DME supplies, where we should be placing backup generators, how we optimize shelter placement, where we might see higher volume of EMS calls for these kinds of complaints. So it's really very applicable information. And then always there are some limitations we should acknowledge. Firstly, this is a limited population with a limited range of DME, and it doesn't include persons dependent on other forms of DME. So for example, ventricular assist devices, oxygen concentrators, things like that. And it was part of a single hospital system. So while this tool right now provides a lot of information for that single hospital, it doesn't account for all the patients at other hospitals in the city. And also analysis that depends on location of residence and hurricane inundation models can't fully quantify an individual's risk of losing access to power in an emergency because it doesn't account for location and fortifications of power stations, access to community power supplies, maybe at libraries or community centers, whether or not the household is on a priority restoration list or if they have an evacuation plan. So there are a lot of other extraneous factors that influence an individual's access to power. And quantifying the population at risk based on residents within an inundation zone also ultimately underestimates the true population at risk because damage to electrical infrastructure in a flood zone may result in power outages affecting non-inundated zones, like we saw during Hurricane Sandy. And so going forward, there are a lot of opportunities to expand here, expanding the categories of DME we're going to look at, including other hospital data. And this approach is very adaptable to non-hurricane climate hazards like heat waves and snowstorms to really give a more complete and accurate picture of the electricity dependent population at risk. My references, and I'm happy to take questions now, or please feel free to reach out to me later. Thank you.